Today we will be discussing about the bundle branch blocks. And in order to talk about the bundle branch blocks, first we need to know the conduction pathway of the electrical impulses which are generated in the heart. As everyone knows, the ECG is all about the electrical activity of the heart. It hasn't got anything directly to do with the mechanical activity of the heart, which we actually know of by with the help of the pulse. So the electrical conduction pathway, as we know, it starts from the sinoatrial node, which automatically generates impulses at a rate of 60 to 90 times per minute. From the SA node, the impulse goes through the Batchman tract to the atrial muscle, causes its depolarization, and which generates a P wave on the ECG paper. As the impulse moves from the atria to the ventricle, there is a door which we call atrioventricular node. And this is the only point in the conduction pathway where the impulse is delayed for a fraction of a second. And the aim of this very delay is to give time to the ventricle to be filled with the same blood which is coming from the atria. And when this impulse, after traversing through the AV node, enters into the bundle of His, and where its speeds again becomes very fast, then it enters first into the septal branch of the conduction pathway, which depolarizes the septum. And this depolarization of the septum generates a very small R wave in lead V1 and V2, and a very small physiological Q wave in lead V5 and V6. Almost after a very few fraction of the second, this very impulse, the same impulse enters into the right bundle branch and the left bundle branch of the conduction pathway. Once there, it rapidly goes to the Purkinje fibers and causes the and which then enters into the ventricular muscle. There it causes the depolarization of the ventricular muscle. The depolarization of the both right and the left ventricle happens simultaneously, and it generates QRS complexes. Because if we look at the placement of the chest leads, V1 and V2, they are located towards the right side of the chest or towards the right ventricles, and V5 to V6 are located towards the left side of the chest or towards the left side of the heart. So whenever we are to find out anything happening to these chambers, right or the left, we are to actually consider the respective chest leads. So when ventricular muscle are depolarized, it generates QRS complexes in all of the chest leads. So this is the conduction pathway of the electrical impulses which are automatically generated in the SA node, and then they move all the way down towards the ventricular muscle, and this is how the QRS complexes and the P wave are generated, and the ventricular repolarization causes the generation of the T wave. Now, if we look at the conduction pathway of the impulse generation and its transmission into the heart, we see it is generated in the SA node, sinoatrial node, which is located in the right atrium, at around the area where the superior vena cava enters into the right atrium. So SA node or sinoatrial node is located in the right atrium, and it automatically generates impulses at a rate of 60 to 90 times per minute. Although it is under the effect of sympathetic and the parasympathetic systems for its rapidity and being slow, but nothing causes it to generate impulses. It automatically generates impulses at this rate of 60 to 90 times per minute. From the SA node, these impulses moves into the atrial muscles through the Batchman tracts. It causes the depolarization of the both atria simultaneously, and it generates P wave on the ECG paper. The first of the P wave is caused by the depolarization of the right atrium, and the descending or second part of the P wave is caused by the depolarization of the left atrium. From the atria, this impulse enters into the ventricle through a door known as the AV node, which is located at the junction of the both atria and the ventricle. So this AV node or atrioventricular node is the only point in the conduction system which delays the impulse transmission from the atria to the ventricles. And why we as a humans or the living things needed this AV node? Because the blood which is coming from all of the body through the venous system into the atria will go from the atria to the ventricle, and then the ventricle would contract, and they would cause the dead blood to enter to the rest of the body through the arterial system. So there needed to be a delay where the atria are emptied and the ventricles are filled with the same blood. So there is a very short delay of impulse transmission from the atria to the ventricle, and this very delay is shown on the ECG paper as PR segment. The definition of the PR segment is from the end of the P wave to the start of QRS complex, whereas the PR interval is the time from the start of the P wave to the start of QRS complex. So the very time in which impulse is passing from the atria to the ventricle is the one which is shown on the ECG paper as the PR segment. So after this slow impulse transmission through the AV node, this impulse enters into the bundle of the His and it regains its speed once more. In fact, it becomes faster than before. From the bundle of the His, the first part enters into the septal branch and causes the depolarization of the septum. This depolarization of the septum is shown on the ECG paper as a very short PR in R wave, a very short positive deflection or R wave on the chest lead of V1 and V2. Why V1 and V2 normally have a very small positive deflection? Because V1 and V2 are located sort of right in front of this septum. So when this weak depolarization of the septum moves towards V1 and V2, it generates a positive deflection which we call a small R wave. But at the same time, V5 and V6 are located on the left side of the atrium, like we can say this side. So this wave of depolarization is going away from V5 and V6, and when a wave of depolarization is going away from any lead, it generates a negative deflection. So we have a normal physiological Q wave or the negative deflection because of the septal depolarization going away from the V5 and V6. So once this impulse has first entered into the septum, it at the same simultaneously it enters into the right and the left bundle branches. Rapidly it goes towards the Purkinje fibers, which are located at the very end of the these two bundle branches. There is one single right bundle branch, but there are two fascicles of the left bundle branch, posterior fascicle and the anterior fascicle. If we look here, this is the posterior fascicle of the left bundle branch, and this is the anterior fascicle of the left bundle branch, and these both have Purkinje fibers which are embedded into the ventricular muscle. So depolarization of the ventricular muscle happens under the effect of this impulse, which is coming all the way from the SA node to the atria, AV node, bundle of His, both bundle branches, Purkinje fibers, and when there is depolarization of the ventricular muscle, it causes QRS complex. Because this phenomena of depolarization is in the both right and the left ventricular is happening almost simultaneously, so there is a very short QRS complex. But when this impulse dies down, it finally goes towards the towards the area which is separating the atria and the ventricle, and it strikes it and dies down because it's going away from it. So it generates a very short downward deflection known as the S wave. The ventricular repolarization causes the T wave on the ECG, and the depolarization causes QRS complex, and atrial depolarization causes P wave. So P wave is a very simple phenomena, but the QRS complex has got three components. Q wave is formed by the Septal depolarization. R is formed by the depolarization of the main ventricular muscles, and the S wave is formed by the phenomena in which the very same wave of depolarization is going away from the leads before it dies down after striking this fibrous tissue which separates atria and the ventricles. And T wave is generated. Okay, there is a very short interval which we call the ST segment, which is between the T wave and the last part of the QRS complex, S wave. So that is an area where there is electrical neutrality. The ventricle is not depolarizing or repolarizing, so it is a sustained depolarized state. So that generates a straight line. So after that, when the ventricle depolarizes, it causes when the ventricle repolarizes, it causes T wave. So this is a complete conduction pathway of the electrical impulse transmission. Now there is another way of looking at the conduction pathway. SA node generates automatically impulses which go towards the Batchman tracts, enters into the atrial muscle, which causes the generation of P wave on the ECG paper. Then from the atrial muscle, it enters into the AV node, which is depicted on the ECG paper as the PR segment, which is from the end of the P wave to the start of QRS complexes. And from the AV node, it enters into the bundle of the His. From the bundle of the His, it first enters into this septal branch of the conduction pathway. That depolarization of the septum generates a small R wave in lead 1 and V2, and a small Q wave in lead V5 and the V6. Along with it, it also simultaneously enters into the right bundle branch and the left bundle branch. And it causes the depolarization of the ventricular muscle, which generates a QRS complex, especially R and the S, because the Q has already been generated by the septal depolarization. So before we go for the right and the left bundle branch blocks, we need to understand the duration of the QRS complexes and duration of the small boxes, because duration of one small box is 0.04 second, and because the QRS complexes normally they are less than three small boxes, so the width of a normal QRS complex, which we call the narrow QRS complex, should be less than 0.12 second. Why they are narrow? Because the impulse which was generated into the in SA node, it simultaneously causes the depolarization of both the right and the left bundle branches, and this phenomena is happening so rapidly that at the end it generates a very narrow QRS complex. Most of the time it should always be less than 0.12 second at the three small boxes. So whenever we are looking at ECG paper, we should have an idea what is the duration of one small box, what is the duration of three small boxes, what is the duration of one large boxes, what if the duration of the QRS complexes is more than what we are seeing the narrow QRS. So in order to actually better understand the QRS complexes width, we need to know the duration of the small boxes and duration of the large box. Duration of one small box is 0.04 second in duration, and the duration of one large box which has got five small boxes is 0.20 second, and duration of the two small boxes is 0.08 second, and duration of three small boxes is 0.04 into 3, that would be 0.12 second. Normally the QRS complex is always less than three small boxes or less than 0.12 second in duration. And why the QRS complex is narrow? Because the impulse rapidly moves from the bundle branches to the ventricular muscle and causes its fast depolarization, and these simultaneously depolarize, and it generates a very narrow QRS complex in which actually there is depolarization of both the right and the left ventricular muscles, but because the phenomena is happening so simultaneously that there is no two displays of the ventricular muscles. There is a single display in the form of a very narrow QRS complex normally. So in order to understand the right bundle branch block, we should first understand how normally V1 is generated, why there is a very short R wave, why there is a deep S wave in the lead V1 and V2. The reason behind being the R wave being the smaller one, the positive deflection, a very small positive deflection, is because of the septal depolarization, because if you consider lead V1 and V2, they are located in the on the right side of the sternum. Lead V1 is located on the right side of the sternum in the fourth intercostal space, and lead V2 is located on the left side of the sternum in the very same fourth intercostal space. And these both V1 and V2, they are sort of overlying on the septal side of the heart. So when the septal depolarization first of all, there is depolarization of the septum. When that septal depolarization is moving towards V1 and V2, it generates a very small positive deflection, which we know as the R wave. Later on, when because of the two, of the right and the left ventricle, the larger one is the left ventricle. So when there is depolarization of the right ventricle, at the same time there is depolarization of the left ventricle, and because the muscle mass of the left ventricle is larger than the right ventricle, so the depolarization and its effect on the ECG of the right side of the ventricle is masked by the depolarization of the left ventricle, because the left ventricular depolarization is going away from the V1 and V2, so it generates a deep S wave. No positive deflection other than a very small R wave because of the septal depolarization in lead V1 and V2. A very deep S wave because the wave of depolarization in total is going away from lead V1 V2 because of the larger muscle mass of the left ventricle, which is located in opposite side of the lead V1 and V2. So it generates a deep S wave, and then of course there is repolarization of the ventricular muscle, which generates a T wave. So when we look at the normal morphology of the lead V1 and V2, there is a small positive deflection of R wave, a deep S wave, and then there is a T wave. So we call V1 and V2 negative leads of the ECG. So the normal morphology of lead V1 and V2 tells us one thing, that there is a very small positive deflection, which we call a small R wave, and it is because of the septal depolarization of the heart system. And there is why there is a deep S wave. This deep S wave is because in total or in aggregate, the wave of depolarization of the ventricular muscle is going away from lead V1 and V2. Why it is going away from the V1 and V2? Because both the right and the left ventricle, they are depolarizing simultaneously, and every one of us knows that right ventricle is no more than a pocket. It has got a very small muscle mass. So when the larger left ventricle is depolarizing at the same time, it has got its major impact on the morphology of the chest leads, because the wave of depolarization is going away from lead V1 because the left ventricle is located in a direction opposite to lead V1 and V2. So the lead V1 and V2, they see the wave of depolarization going away from them, they generate a deep S wave. So normal morphology of the V1 is, it has got a small R wave, a deep S wave, and a narrow QRS complex, which is less than 3 small boxes or less than 0.12 second in duration. So now what happens in right bundle branch block? The impulse from the AV node enters into the bundle of His, causes the septal depolarization, which generates R wave, which is obviously more than the UL in the height. So this R wave is because of the two reasons. One, because there is a septal depolarization, and then there is a augmented depolarization of the left ventricular muscles. Why augmented? Because there is a blockage in the bundle branch, which is located on the right side, or right bundle branch block. So V1 and V2, they are perceiving the wave of depolarization of the left ventricle coming towards them along with the septal depolarization. So there is a tall R wave initially. Then there is ventricular depolarization of the left ventricle. Up till now, the impulses haven't got towards the right side of the heart. So this wave of depolarization now, when it moves away from the V1 and V2, it generates a deep S wave. Initial was the positive deflection, but now it is giving a negative deflection. By the time it is about to die, these very impulses through the ventricular muscles, they reach the right ventricle and causes the right ventricular depolarization, which the lead V1 and V2 perceive as an other positive deflection coming towards them, and it generates R prime, an other notch, positive notch, and other positive deflection in the lead. In this process, two things happen in lead V1 and V2. First, there is a rabbit ear pattern or RSR pattern in the lead V1 or V2, and second thing is this very phenomena causes the broadening of the QRS complexes, which was initially narrow QRS complexes less than three small boxes or 0.12 second. Now it has become more than three small boxes or more than 0.12 second. So the definition of the right bundle branch block goes with, there is a broad QRS complex more than 0.12 second, and there is a RSR pattern or rabbit ear pattern or RSR prime pattern in lead V1 and V2. This is what we call right bundle branch block. Now the major causes of the right bundle branch block are right ventricular hypertrophy, pulmonary embolism, ischemic heart disease, rheumatic heart disease, cardiomyopathy, hypertension, atrial septal defect, and Brugada syndrome. These are some of the major causes of the right bundle branch block. In order to understand the left bundle branch block, we should first talk about the normal morphology of the lead V5 and V6. If we look at the position of the lead V5 and V6, they are located towards the left side of the chest. In the fifth intercostal space, V5 is located in the anterior axillary line and V6 is located in the mid axillary line, both in the fifth intercostal space. So they are located more towards the left ventricle as compared to V1 or V2, which are located more towards the right ventricle. So any changes in the left ventricle or its conduction system would be more detectable in the lead V5 and V6. Normally V5 and V6, they are narrow complexes less than three small boxes or less than 0.12 second, and they have got P wave because of the atrial depolarization. A very small Q wave, which we call the physiological Q wave, because it is less than 1.5 small boxes in the depth. So that physiological Q wave is formed by the septal depolarization going away from the lead V5 and V6, and a tall R wave, which is formed by the depolarization of the ventricular muscles, left ventricular muscle, which are moving towards the lead V5 and V6, and a very small downward deflection of lead S. Why it is formed? Because when the wave of depolarization are turning towards the fibrous tissue which separates the atria and the ventricle, it sort of goes away from the V5 and V6 and again gives a negative deflection. Then there is a sustained depolarization segment of isoelectrical activity or neutrality, which we see as the ST segment, isoelectric line, and then there is a wave of repolarization going away from, though it is coming towards the V1 and V2, but is negating its effect. So there is a positive deflection on the lead V5, V6, which we call T wave on the ECG paper. So in order to understand the left bundle branch block, we should understand the morphology of normal V5 and V6. So the normal morphology of V5, V and V6 is that there is a narrow QRS complex of less than 0.12 seconds. Why it is narrow? Because there is a very rapid movement of the impulse through the ventricular muscle causes its depolarization so fast that it generates a very narrow QRS complex, which is less than three small boxes in duration. Why we have a very short or physiological Q wave? We call it physiological because it is less than 1.5 millimeter in depth. If it is more than that, we call it the pathological Q wave, which is entirely a separate topic to discuss. So why we have a QRS physiological Q wave? Because of the septal depolarization going away from lead V5 and V6, because septum is located towards the right side of the heart, and V5 and V6 they are located towards the left side of the heart. We have R wave because of the major ventricular muscle depolarization, which are moving towards V5 and V6. So it generates a very tall positive deflection of R wave. Then we have S wave, which is a negative deflection. Why we have S wave? Because those ventricular muscle which are located and near an area of the fibrous tissue which separates both the atria and the ventricles. So when there is depolarization of those muscles which are located away from the lead V5 and V6, so the V5 and V6 leads, they see their wave of depolarization sort of going away from them, and it generates a very small negative deflection which we call lead S. So this is a normal morphology of lead V5 and V6. So it will help us in knowing the changed morphology in cases of the left bundle branch block, because whenever we are to see anything happening in the right chamber of the heart or the right ventricle, we are to give attention to lead V1 and V2 because they are located near to that area. But when we are to talk about the left ventricle of the heart, then we are to consider lead V5 and V6 because these are the very leads which are located in the neighboring area of the left ventricle. I hope up till now you have already understood the basic phenomena behind broadening of the QRS complexes in case of the right and the left bundle branches, because both the right and the left muscles or the ventricles, they were simultaneously depolarizing. So it wasn't evident on the normal morphology of the V1 or V2 or V5 or V6 because the phenomena was happening all at the at one time. But this time around, when there is a blockage in the right or the left bundle branch, first the one which hasn't got the block will depolarize, but ultimately the second muscle will also depolarize through the phenomena of the ventricular movement of the electrical impulses. In the normal cases, the electrical impulses they traverse or travel through the conduction pathway. But when there is a blockage, those very same impulses they first go through those branches which are not blocked. Once they have caused the depolarization of the normal side of the heart, then through the ventricular muscle, jumping from one ventricular muscles to the other, this wave of depolarization will ultimately reach the other muscle and would cause depolarization of the blocked area of the myocardium. So in this phenomena, what happens that there would be broadening of the QRS complexes, and then there would be two notches because why we had narrow QRS complexes initially, because the depolarization and the following contraction of the ventricular muscles was simultaneously, but now it is happening one after the other, so both of them create their own positive deflection or notches in their respective leads. So when I say respective, the one which are located right in front of them, in case of the left ventricle V5 and V6, and in case of the right ventricle V1 and V2. So in left bundle branch block, there is blockage of the left bundle branch. Initially the right, through the right bundle branch, impulse goes to the right ventricle, causes its depolarization. Then through the ventricular muscle, it goes towards the left ventricle, and when depolarization of the right ventricle is about to vanish, it causes the depolarization of the left ventricle. So in lead V5 and V6, you will have double notches, and there will be broadening of the QRS complexes. So whenever you see a broad QRS complexes more than three small boxes in V1 and V5 and V6, and obviously in other leads as well. But in lead V5 and V6, you will have an M pattern, or there would be double notched R wave. So that is the definition of the left bundle branch block. So in cases of the left bundle branch block, when we look at the this diagram or cartoon of the conduction system, we see that there is a blockage in the main branch of the left bundle branch, because it has got two fascicles. So not about the fascicles here, it's about the main branch of the left bundle branch. When there is a blockage, there would be initially a depolarization of the lead, depolarization of the right ventricle, and when it is done, then the same impulse would move through the right ventricle, and it would go towards that myocardium which is located on the left ventricle. So, so the depolarization of the side of the heart or right myocardium or the right ventricle would cause a wave of depolarization which is positive in lead V5 or V6. Why it would be positive? Because there would be a silence on the left side. So the lead V5 and V6, though they are located away from the right ventricle, they would see the impulse or wave of depolarization coming towards them because their own ventricle, which is the left ventricle, is silent at that time. But at the same time, one phenomenon is also happening, that through the movements of the impulse from one ventricular muscle to the other, that impulse would come towards the left side of the myocardium. And when the right myocardial depolarization is about to end and it starts the downward deflection, there would be another positive deflection because of the depolarization of the left ventricle. Because right ventricular mass is a very small one, so there will not be that much downward deflection or S wave as it was in the lead V1 or V2 in cases of the right bundle branch block. So it would generate one normal R wave, and then there would be a downward deflection, then there would be another positive deflection because of depolarization of the left myocardium or left ventricle. Now this impulse is not coming through the left bundle branch block, but it is coming through the ventricular muscles from the right side of the myocardium. So there would be an M pattern in lead V5 and V6, and there would be broadening of the QRS complex more than 0.12 second. So the definition of the left bundle branch block is that there would be broad QRS complexes in lead V5 or V6, and there would be M pattern or R prime pattern in lead V5 or V6. Now, clinically speaking, there are so many cases where we see patients and do not find a specific pattern in lead V1 or V2 or V5 or V6. These are the cases where there is a broad QRS complexes in different leads. Then you will have to see lead V1. If along with the broad QRS complexes there is a deep S wave in lead V1, it would be left bundle branch block. But if along with broad QRS complexes there is a tall R wave in lead V1 or V2, it would be known as the right bundle branch block. I'm talking about that confusion which happens when you do not find a specific pattern in V1 or V2 or V5 or V6. Then you will have to look at the status of the V1, and obviously there should be a broad QRS complexes. It is the basics of bundle branch blocks. So when we say that what is the definition of left bundle branch block, it is broad QRS complexes, i.e. more than 3 small boxes are 0.12 second, and M pattern or R prime pattern in lead V5 or V6 is known as left bundle branch block. There are some causes of the left bundle branch block. These are acute myocardial infarction, aortic stenosis, dilated cardiomyopathy, extensive coronary artery disease, aortic root dilatation, primary disease of the cardiac electrical conduction system. So these can be major causes of the left bundle branch block. What I see as a practical doctor in the intensive care unit, most of the time, 2 or 3 types of patient present to us with the left bundle branch block. When a patient is presenting with certain complaints, for example, shortness of breath, chest pain, and patient has got certain risk factor like being diabetic, hypertensive, has got a family history of coronary artery disease, is smoker, is following a sedentary lifestyle, has got a type A personality as a stressful personality, is male, and when such a patient comes to the emergency department or ICU, and he's got an ECG 1 month back or 15 days back or 6 months back, and you see this time that the ECG shows left bundle branch block changes. The broad QRS complexes and M pattern or R prime R pattern in lead V5 or V6. And if even if you do not find the pattern and you have a broad QRS complexes and then you look at the lead V1, there is a deep S wave in the lead V1, then you know that this patient has got a left bundle branch block. The main decision you are to take whether this is a new onset left bundle branch block along with the symptoms or an older one. By looking at the past record of the patient, if available, and you find out that this patient has got a new onset left bundle branch block and he has got symptoms, then you treat it as an ST elevation MI, a major heart attack. Then you go for the angiography, angioplasty, whatever you can do, or you can give clot buster like the tissue plasminogen activator. But there is another group of the patient who have a past record of already having left bundle branch block. They haven't got the workup further. For example, they never had a angiography. Now again they present with certain symptom. Now you are to assess them clinically. If someone has got previous record wherein you find left bundle branch block in the ECG, and patient still has got chest pain, you will have to treat him according to the ischemic acute coronary syndrome criteria. But these patients should have echocardiogram to have myocardial dyskinesia, akinesia, or hypokinesia. So, new onset left bundle branch block is treated as acute coronary syndrome, especially ST elevation MI. But the previous one are most of the time they present with the heart failure, and they have already existing myocardial damage. But in any case, a diagnosis of left bundle branch block especially is very important, and most of the time those patients who present with a new onset right bundle branch block, they are treated as non-ST elevation MI or a moderate heart attack, because they have got involvement of the right side of the heart, and there are chances that right coronary artery has got some thrombus in it.